Assalamu alaikum. Today's lecture is on connective tissue diseases. Again, very important topic. It's very important to master and grasp all the information here. This topic is very important. Again, there are rates of morbidity and mortality. This topic includes disorders of multi-system nature, wherein multiple vital organs can be involved, such as the kidney, as happens in lupus nephritis, or lungs in interstitial lung diseases related to these connective tissue disorders. To start with, it's very important not to get the term heritable connective tissue disorders confused with autoimmune connective tissue disorders. A big example for heritable connective tissue disorder is Marfan syndrome. You all know about Marfan's syndrome. Very tall height, vascular complications such as aortic aneurysms, and also lens dislocation. These are main features, whereas examples for autoimmune connective tissue disorders are lupus, systemic sclerosis, Sjogren's syndrome, mixed connective tissue disorder, overlap syndromes, and also in relation are the inflammatory myopathies. So connective tissue diseases are subsets that can be distinguished clinically and serologically. The findings can evolve over a number of years. You can have a patient with lupus who's starting with some Raynaud's, some skin rash, arthralgia, positive ANA, but in another few weeks or months they might develop further complications or features such as lupus nephritis or interstitial lung disease. So not necessarily that everything will happen at the same time. Organ failure can happen. There is variable mortality rates according to the condition and the severity. You will notice many interesting clinical signs, things like skin rashes and the multi-system nature of these disorders makes them very interesting to study and to go through the details of which. Raynaud's can be considered as very common association to connective tissue disorders. We all know that Raynaud's can be either primary as a standalone condition due to vascular spasm of idiopathic nature, usually more common amongst smokers and in people who do not look after themselves in terms of keeping warm. However, it can be a secondary phenomenon occurring alongside the connective tissue disorders. Also, Raynaud's can be sometimes so severe that they can cause tissue loss, sometimes loss of fingertips, and therefore very important to deal with this condition quite seriously. In terms of lupus, note that lupus has a systemic form which is called systemic lupus erythematosus, or the discoid lupus. Discoid lupus, if it happens on its own without other systemic features, then it can be considered as a dermatological disorder. If it is occurring in the context of systemic features and the criteria of SLE, then it will be a part of the criteria, then it is a part of the systemic lupus. Sometimes lupus can present as a subacute cutaneous form, usually on the areas exposed to the sun. There is also a category called drugs-induced lupus, and there are some drugs that are associated with drugs-induced lupus. We will be going through these examples as well as a bit of information that you need to always recall that neonatal lupus can occur in newborns, usually to the mothers known to have lupus. And also there can be passage of certain autoantibodies. Patients with lupus and with other condition called Sjogren's syndrome can have anti-Rho and anti-La antibodies. These can cause heart blocks in the newborns, and hence it's important to get these classified and known in the mothers and to manage that for them. The doctors looking after the newborn should be made aware before the delivery, so that, for example, if a pacemaker for the baby is needed, then that can be prepared in advance. Now we will be going through the pathophysiology of SLE. The mechanism as to how SLE develops is not entirely and exactly known. Most theories are around the theme of interaction in between genetic susceptibility with environmental stimuli that result in autoimmune proliferation and therefore autoantibody production causing inflammation. It's, however, very important to be aware of the systemic nature of SLE and to realize the how the organs get affected by SLE. So going through the criteria of SLE, malar rash, what is specific about it is that it is spare the nasolabial folds. We always recommend sun blockers for the patients who are known to have SLE. Sun is known as a triggering factor for flares of SLE, especially the skin disease. Discoid rash, again, I've mentioned about discoid rash earlier. Discoid lesions can be scarring and they can cause some long-term marks on the skin. If a discoid lesion is occurring on its own, then that is a dermatological problem, purely a dermatological problem. However, it is also a criteria amongst the other criteria for SLE. So if a patient develops it as a part of SLE, then it counts as one of the criteria. Photosensitivity, it's very important for these patients to be told about the bad effect of sunlight to them. Sun avoidance is always recommended. Oral and nasal ulcers are also a feature of SLE. They are not necessarily so painful as the ones that are found in Behçet's disease, but they are a common feature. In terms of arthritis, it's usually not erosive. Although arthritis is not usually erosive, it is usually of inflammatory type. So you will have things like early morning stiffness, you will have features of synovitis, and you will have the type of pain that is worse in the early morning, which usually gets better throughout the day as the time goes on, as the time goes in the day, um, 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 and also on gentle exercises. Serositis, an additional criteria. Pleuritis is a common finding. However, here it's very important to remember that patients with SLE do have hypercoagulable states. Therefore, if a patient develops pleuritic chest pain, it's important to always keep the possibility of pulmonary embolism on mind, and not always to take it for granted that this is a benign pleurisy. Renal disorder. This is very important. It's very important to keep checking the blood pressure of patients with SLE on their follow-ups. We need to screen their urine samples and to look at findings of protein, hemoglobin, or red cells or casts. These are usually features of an ongoing renal disorder. Sometimes renal disease can be quite silent, so it's very important to catch it and to diagnose it, even if the patient is not symptomatic at that stage. Neurological disorders such as seizures or polyneuropathy. Again, we have with things like seizures, this can be due to SLE itself. However, we should also keep in mind that these patients are immunocompromised. They can develop, for example, septic processes such as septic meningitis. Therefore, it is important in the first instance to rule out infections and other causes for such presentations, such as uremia, electrolyte disturbances, or ketoacidosis, if they were having clinical signs and reasons compatible with it. Otherwise, we should assess for the possibility of an active lupus or lupus as an underlying cause for these features. Blood disorders can affect any of the hematological lines, so hemolytic anemia, leukopenia, lymphopenia, and also thrombocytopenia. All of these findings can occur. The immunological disorders are represented by the abnormality of the autoantibodies, so positive anti-double-stranded DNA or anti-SM or antiphospholipid antibodies. Remember that antiphospholipid syndrome is more common among the patients with SLE. However, antiphospholipid syndrome can be a standalone disorder. ANA is considered as a separate criteria, so it is not considered here in terms of criteria designed to be a part of the immunological disorder. This one counts separately. So positive ANA is a separate criteria. Now we have to have a more close look at the autoantibodies. Because ANA is positive in about in almost all patients, so it is considered a best screening test. If a patient is ANA negative, this makes the diagnosis very much doubted. However, it doesn't entirely rule it out. In terms of anti-double-stranded DNA, these are specific for SLE itself, and they tend to correlate with disease activity. Also, anti-SM are specific for SLE. The fourth one you would see on the page is anti-RNP. It's positive in around 40% of patients with a disorder called mixed connective tissue disorder. However, it can also be present in other connective tissue diseases. Regardless of what disorder it's associated with, whenever RNP is positive, we always need to look for involvement of the heart by inflammatory processes. So things like inflammatory myocarditis can be more common in patients with anti-RNP, and then we need to screen these patients for any features of cardiological disorders. Anti-Rho, anti-La, we've mentioned about these earlier, and we've mentioned about the congenital heart block syndrome. Anti-Rho, anti-La are also present in Sjogren's syndrome, which is another example of connective tissue disease. I'm sure that you all heard on the news about the drug hydroxychloroquine. This is the anti-malarial, which is now being considered for its potential beneficial effect against coronavirus. So this is originally an anti-malarial drug. It's useful in the treatment of the cutaneous features of SLE. And also review your pharmacology for the disease modifying antirheumatic drugs such as methotrexate. There are different indications for these medications. Try to refresh your memory on some of the specific findings. For the specific side effects of each of these medications. For example, you might remember that cyclosporine is a medication that can cause gum hypertrophy and hypertension. Azathioprine can cause low-grade lymphomas on the long-term use. Methotrexate can cause acute pneumonitis. Cyclophosphamide, for example, is accused of causing bladder cancers on the long term and also hemorrhagic cystitis. So please refresh your memory on your pharmacology. In terms of biologics, there is an increasing role for rituximab and other biologics. And as you know, in terms of steroids, we tend to use them for flare-ups and at the induction stages when these conditions are presenting initially in a very active fashion. So steroids are of a quick onset of action and therefore they are needed. Uh, Now mentioning about some of the bad prognosis factors. Renal disease, hypertension, um, male gender and younger ages. So in terms of the age, you can look at this as, and you can think about it, that if a young person has got SLE, they're gonna live with it throughout their life, so longer period of exposure to an inflammatory process. On the other hand, older age at presentation, SLE would tend to be of high severity in the older people. Also the black race and presence of additional problems and comorbidities, including antiphospholipid antibodies. In terms of drug-induced lupus, so we need to remember that some drugs can cause some lupusy features. Drug-induced lupus tends not to be very severe and tends to avoid vital organs. So this is a list for the most common medications that can cause drug-induced lupus. Remember these on taking your medical histories. And here's some comparison for you in between SLE and drug-induced lupus. See how renal involvement is rare, neuro involvement is rare. And look at the autoantibodies profile. Please note the association of anti-histone and anti-double-stranded DNA. These are helpful in making a diagnosis and distinguishing in between them. So anti-double-stranded DNA is usually negative in drug-induced lupus. In fact, an exception for this is when lupus is caused by the biologic medications, where anti-double-stranded DNA can still be positive. In terms of the anti-histone antibodies, although they are positive in 95% of the drug-induced lupus, they can also be positive in SLE itself. Therefore, I would be looking at the negative predictive value for antihistones. In other words, if antihistone is negative, it makes drug-induced lupus less likely. This is to remind you about the neonatal heart block syndrome in association with anti-LA, anti-Rho antibodies. Now a quick review on the antiphospholipid syndrome, which you should also be studying as a part of your hematological studies. This is a syndrome that can be responsible for recurrent venous or arterial thrombosis and sometimes unprovoked thrombosis. Also, it can be a cause of fetal losses and pregnancy problems. Antiphospholipid syndrome is associated with positivity of certain autoantibodies, and this is for your further study to read about the anticardiolipin, IgM, IgG antibodies, antiphospholipids, and the lupus anticoagulant. So Raynaud's doesn't have an L in it, so sorry for this typing error. We've seen this, we've talked about this. Now, Sjogren's syndrome is another example of a connective tissue disorder. Sicca syndrome, dryness of the mucous membranes, especially at the level of the eyes and the mouth, is a very prominent feature. Remember that mouth dryness can result in secondary problems as well. For example, difficulty swallowing. This is a point for you to consider on taking histories. Try to distinguish between a true dysphagia and a difficulty swallowing that is due to secondary causes, such as dryness of the mouth. It's very common for patients with Sjogren's to have muscle aches, things like myalgia, in addition to arthralgia, joint pains, and some of them also develop neuropathy, and less common than in SLE, they can develop renal problems as well. Sjogren's is famous for its association with other autoimmune conditions, such as with rheumatoid arthritis and with SLE. Also, it can be associated with primary biliary cirrhosis and liver disease. One more fact about Sjogren's syndrome is that patients with this syndrome are more liable to develop malignancy over time. This is not very common, but it is more common for patients with Sjogren's to develop malignancies, and therefore we should always keep this on our mind when we follow up these patients. Now, going to an additional big example on connective tissue disorders, which is systemic sclerosis. Have some time to look at this page. And as this picture. Note the extent of telangiectasia on the hands and on the face. Look at that face and see the appearance of the nose and the mouth. Very tight skin. The nose is taking the appearance of a punched nose. Sometimes there can be peaking of the nose. And if you are to feel these hands, they are going to be very tight. The skin will be very tight. The fingers will be contracted due to the tight skin and the subcutaneous tissues. And look at the ulcer formation. Crest syndrome is a variant of scleroderma. CREST, calcinosis, Raynaud's, esophageal dysfunction, usually with acid reflux, sclerodactyly, and telangiectasia. Patients with scleroderma can develop a scleroderma crisis, usually with renal impairment, high blood pressure. Remember that ACE inhibitors and angiotensin converting enzymes inhibitors are the first line of treatment. Remember that generally in internal medicine, you would have been taught that ACE inhibitors are to be withheld during acute renal impairment. However, this is a big exception. So in scleroderma crisis, the first line treatment will still be ACE inhibitors. Another point for further reading and study is to make sure that you are aware of the general principles on how to deal with SLE flare-ups. And remember that patients can have a mixed connective tissue disorder, usually involving features of SLE, polymyositis, and scleroderma. If a patient does have a full criteria for one connective tissue disease in addition to a full criteria of another connective tissue disease, then they will be termed to have an overlap syndrome. This is going to be different to mixed connective tissue diseases. So overlap syndrome, an example is when you have a patient with well-established rheumatoid and then they develop a well-established SLE. Then that is going to be overlap of SLE and rheumatoid. Whereas if a patient does have a little bit of features of RA and some features of SLE, and especially if they have the anti-RNP antibody, then they will be called to be having MCTD, that is the mixed connective tissue disorder. Inflammatory myositis and dermatomyositis. These are again topics associated with morbidities and mortalities. Occasionally they can be paraneoplastic occurrences, and therefore it's very important to screen for underlying malignancies. So this page takes you through some of the related conditions. In terms of PMR, as you know, polymyalgia rheumatica is usually a benign disorder characterized by muscle stiffness and myalgia, with some elevation in inflammatory markers such as CRP and ESR. It doesn't cause muscle weakness, it causes only aches and pains and stiffness. Also in PMR, we should keep the possibility of underlying malignancies on mind. So when you take clinical history and perform your physical examination, do always ask about things like weight loss, loss of appetite, lumps and bumps, and on physical examination do look for organomegalies, lymphadenopathies, or unexplained neuropathy. Look at the blood tests and make sure that these patients are not having some hints towards malignancies such as hypercalcemia, unexplained anemia, or hyponatremia. Polymyositis is the involvement of muscles with inflammation without the presence of skin manifestations. Patients with myopathies would usually complain about things like rising from chairs, climbing steps, combing hair, and these are usually due to weakness in the proximal groups of muscles. They can also have dysphagia and failure of the respiratory muscles, and so a risk of respiratory failure. The physical examination would be focused at demonstrating the presence and extent of muscle weakness, and also to exclude any presence of neurological disorders or findings. However, the muscles can be tender on palpation. The investigations, the blood test would usually show very raised CK levels. ANA and ENA actually should be performed, in addition to a panel of muscles associated antibodies. The other blood tests aim at ruling out presence of entities that can mimic or cause myopathy, such as thyroid diseases, Cushing's, significant vitamin D deficiency, and viremia. EMG is usually confirmatory, and muscle biopsy is the definitive test. In a practice, muscle biopsy is taken after performing an MRI scan, which can confirm the presence of involved muscles with edema and inflammation, and then it gives us the best anatomical site to as to where to perform the muscle biopsy. Dermatomyositis is most of the findings in myositis are also present in dermatomyositis, but in addition to that, there will be skin involvement, and the skin rash is usually taking the color of these flowers as you see here. Always remember that these are still conditions that, despite their names as dermatomyositis or myositis, they can involve deeper organs such as the lungs, heart, and therefore they are still systemic disorders. Review these findings and conclude with remembering the fact that sometimes dermatomyositis can occur without a myositis at the point, and it can be only an inflammatory dermatitis, which can then continue to be purely as an inflammatory dermatitis, or myositis can be added later in time. This is a characteristic periorbital rash associated with dermatomyositis. I would advise that we always ask and inquire about the use of any cosmetic products, because this can hide these signs. So just to make sure. these are some additional features, and this is a reminder to screen also for malignancy. There is no standardized way as to how to screen for malignancy. But as you develop your clinical knowledge and experience, you are then to acquire your way and clinical sense with this regard. These are the findings of skin and muscle biopsies. Again, remember your pharmacotherapy agents. Remember, there can always be residual weakness and disability, and here there will be significant role for physiotherapy and rehabilitation. Again, these are some Gotran's papules with some telangiectasia, and compare between the hands of someone with dermatomyositis on the right hand side, where you would see the skin lesions involving the bony prominences and the DIP, PIP, MCP joints, whereas on the left hand side the lupus and photosensitive rashes are sparing those areas. So at an initial look you might think that these are similar, but they are very different. Again, this is the V-shaped rash commonly seen in dermatomyositis. Now you need to know that there is a specific syndrome in relation, which is called the anti-Jo1 syndrome, or anti-amino acyl tRNA synthetase antibody syndrome. The main features are arthritis, myositis, fevers, interstitial lung disease, and mechanic hands. Mechanic hands are like the ones you see in this picture. And there are also some additional syndromes. So the one on the top is the same one as of anti-Jo1 antibodies syndrome. Whereas if there is a positivity of anti-SRP or the signal recognition particle, this would usually denote involvement of the heart, which is in a way a bad prognostic point. Make sure that you remember the features of anti-Jo1 syndrome. And remember that myopathies can occur as an overlapping problem to other connective tissue diseases. And a quick mention on the inclusion body myositis, which is more common in elderly, more common in males, and so far there isn't a very effective treatment. However, there is a lot of ongoing research. Some medications, as like what we have seen with lupus, there is a drug-induced lupus. There are medications that can cause lupus, and also there are drugs that can cause myopathies. Again, very important to review your pharmacology. So colchicine is a medication used in gout. It's also used in Mediterranean familial fevers. And there are also some other indications in certain types of pericarditis. Hydroxychloroquine is now becoming the famous drug, especially in this period of the coronavirus. You all know about the steroids side effects and how long-term use of steroids can cause problems like osteoporosis, thinning of the skin and hair, and acne, and also it can cause steroid-induced myopathy. Also, effects of alcohol and cocaine. Keep these differentials on your mind, and always in a practice we should remember not to prescribe muscle relaxants to patients with myopathies. That is all. I hope that you all enjoyed this. Please remember all the information. Please remember that you can ask, inquire, and read more about any point that you haven't fully understood. I hope that studying from home is going well for you all, and I think this is a very good opportunity to concentrate very well, and probably save some times through transportation and socializing. So we expect you to be very good at these topics. In particular, any questions, please let me know. Thank you very much, and very good luck to all of you. Assalamu alaikum.